Hello class, I'm going to present you the material that we would have been discussing on Monday had we had class. But for now, I'll just go over things that I'm able to do so that you're able to at least view and listen to some of the important information that I hope that you get from this day of learning. Our concept today is comfort, and as the definition says, it is addressed through the human experiences of relief, ease, and transcendence in the physical, the psycho-spiritual, socio-cultural, and environmental contexts. Patients achieve relief when their needs are met. Ease is a state of contentment, and transcendence allows patients to rise above their problems. In addition, comfort is related to bodily sensations and homeostatic mechanisms, individual awareness, family, societal relationships, and external surroundings. Increased comfort, reduced stress, and a healing environment allow patients to feel a sense of control over the healing process. Please review your student learning outcomes. And as we talk about this concept of comfort, we again can look on that continuum and look at someone who is extremely comfortable, feeling absolutely no discomfort, feeling comfort within their body, a comfort within their mind, and then we have varying degrees of discomfort. Someone could be in extreme discomfort to mild or moderate discomfort. And I want you to just stop and think about what do you think are the essential elements for comfort. And if we had been in class, it would have been nice just to get everyone's point of view about what they see as things for a person that promotes comfort. And some of the things that I kind of look at is obviously free of pain. Obviously, not being hungry, not feeling anxious. Are you too cold? Are you too hot? I mean, obviously, temperature can make someone very uncomfortable. Someone that doesn't like a lot of areas to live in that are extremely hot or extremely cold. Getting enough sleep, being able to rest. Being clean. This is just a few examples of things that may identify whether or not a person is achieving comfort in their life. And it isn't just comfort that we think in terms of do they have pain or do they not have pain. And another thing I want you to think about is when we talk about comfort, think about one of your very best days. This needs to be an everyday kind of day. And I love to do this activity in class because it's really wonderful to hear really what is your best kind of day. And everybody has their own idea of that. And my best kind of day is just being with my family, being with my grown adult children, maybe going to a family function. In the past, some of my kids, we've gone to Florida, to Walt Disney World, even just going out to eat and celebrating one of the kids' birthdays. Those to me are the best days ever. I just love spending time with my family, or sometimes just sitting out in the backyard on a nice warm summer night, or on a fall October day. As the temperatures begin to fall, building a fire outside and, roasting marshmallows by that fire. So these are my ideas of the best day ever, and I don't think anything can be better than that. And you think about what are those elements in life that created that opportunity to have a good day. And obviously the first one is the people. And we were all in great moods. We all kind of were experiencing a good physical well-being. We all get along, we're family, we love each other, a lot of harmony within those relationships. And we love to be together because that's what families do. So those are some of the elements that really helped make that the best day ever, not just for me, but for the other people involved. And as we continue to talk about this concept of comfort, we also look at some of the factors that exist in our daily life that can hopefully continue bringing us those best days ever. But then unfortunately life isn't that easy. There's things that are happening now in all of our lives that do complicate our life, that prevent us from having those best days ever again and again. And I think one of them for all of you is the fact that now you're in nursing school and you have to devote a lot of time to studying, coming to class, going to clinicals, labs, and then not only doing that, but to fulfill your other responsibilities that you might have. So I think that's really one of the biggest barriers that all of you face in, unfortunately, repeating that best day ever. Mine may not be as drastic as yours. I'm done with school. I just hold a job, and I hope that when I go home, I can enjoy my family and do some of the things that help me experience that best day ever. And I think the point that I'm trying to make here is that knowing that you are now in nursing school, it doesn't mean that you can't have maybe a little piece of those best days ever so that you can experience some level of comfort in your life and not feel frustrated and lonely and angry and resentful, because those feelings and those situations do not promote comfort in our lives. And really what they do is they began to foster stress and anxiety and depression, and unfortunately prevent us from having and experiencing some of the comfort that we hopefully want to do as we live out our lives. So when we think about our personal ideas of comfort, let's focus now on our patient. Think about how they feel as a patient in a hospital, and that they're also unable to experience those best days ever because now their life has become a little bit more complicated because now they're a patient in the hospital. And what kind of things are these people facing, the patients that we care for? Hospitals can seem very sterile to some people, not a friendly environment or warm and inviting. There's a lot of noise in the hospitals, a lot of interruptions. People do not really get a lot of rest while they're patients in the hospital. They have increased anxiety because obviously there's a reason why they are there. And sometimes not all the answers are given yet until some of these tests are back to determine maybe what is the problem and why they're having these issues. Some of these people that come into the hospital may have extreme amount of pain. Their mobilities are limited. Maybe they've went through a very big surgery and their mobility is very limited and they lose somewhat of their independence. They can't do things for themselves anymore, so they have to depend on the nurse or other healthcare workers to just, get out of the bed and use the restroom. So these are things that we really need to think about, that you can see how our patients' level of comfort is seriously disrupted as they are in the hospital, and maybe having you all experience your first clinical week. Think about the patients that you communicated with this week. Did you see how their lives are fulfilled, and what kind of issues that they have that may impair their comfort levels? And I know many of them are in that older adult population. But what kind of things did you see these patients experience that may have disrupted their levels of comfort? And some of them may just have things that you may not think are that big of a deal, but just loneliness can make someone feel very uncomfortable because they just don't have someone to lean on except the staff that are caring for them in that particular facility. And that can lead to a lot of other problems down the way. So it's just something to think about, because I think we always equate comfort with pain, but I think it's a lot more than that, and I think that's the importance of really talking about this concept of comfort, because comfort can come to us in many different ways as we live our lives as human beings. So as we continue on this worksheet, think about the four variables that will make it difficult for a hospital patient to be at their very best, other than the fact that they are a patient in the hospital. And one could be hygiene. Some people, have their routine at home. They shower or bathe every day, wash their hair, able to fix their hair. Women like to put on makeup every day, and sometimes this is extremely altered as they become patients in the hospital. They just really don't feel that total clean or total cleanliness by just having a basin of warm water at their bedside or using those bath wipes that the acute care settings have for other patients nowadays. Nutrition is also altered. Maybe they're very used to having foods cooked a certain way, or they're on a certain kind of diet and they prefer this particular kind of food, and that's just what they usually, eat. I eat this every morning for breakfast, then I have a little lunch, and then this is what we eat at dinner time. And maybe the times that the hospitals or these facilities provide these meals are not that has been in their normal schedule. Oh, I eat breakfast at 7 o'clock in the morning, and they don't get my tray out till 8 or 8:30. Or the breakfast isn't ready till later on. So I'm kind of messed up, because I usually do it because I like to have food on my stomach because of the medications that I take. The social support may not be there. And I think, too, if you've ever been a patient in the hospital, it's that separation from loved ones. And you're basically around strangers. So that can always bring a lot of discomfort to someone and a lot of anxiety. And depending on your personality, you're maybe not the most talkative or the most inquisitive person. So you just kind of sit there or lie there in your room and kind of think about what may be happening and are just a little bit afraid to ask questions because you don't have the social support maybe of a family member around to help you and to understand maybe what's being told to you about your illness. Fear of cost is huge. When people are in the hospital for long periods of time, the first thing they think about is, oh my goodness, how much is this going to cost? I hope all my hospitalization, or I hope my Medicaid or Medicare take care of it, especially if they're from an elder population. So think about your role. I know you're not in the acute care setting, you're at the assisted living or at these facilities with the elderly. Is there anything that you can do to alleviate some of this discomfort from some of the things that I just talked about? How can you improve on hygiene and nutrition? Can you offer more social support? Can you make that discomfort that they're feeling just a little bit less? I'm sure you all can. You all have a lot to offer, and you all can make a difference, even if it's a little difference. After you walk away from your clinicals that day, I'm sure you have left an imprint on some of these patients that you're caring for, or these people that you're in contact with. They really, really appreciate the kindness and attention that you give them. It really makes their day special, and it does give them a lot of comfort. I have this PowerPoint up here. It is a little outline of some of the reading that you hopefully took away from your assignment. So I'm just kind of going to go over some highlights of this PowerPoint. I will download it in your Canvas course so you can have it at a later date for review. These are some of the concept learning outcomes, very similar to your student learning outcomes that are present in your weekly lesson plan. One thing I want to talk about is nursing theories, and you'll learn a lot more about nursing theories as you continue in your education, particularly when you begin your bachelor's degree after graduating here from our program. But I like Catherine Kolkaba's comfort theory, and she defines it as the immediate state of being strengthened by having the needs for relief, ease, and transcendence addressed in the four contexts of holistic human experience: the physical, the psycho-spiritual, the social, socio-cultural, and environmental. And I think you'll notice that this definition was definitely inputted into our definition that we gave you within our curriculum. Think about the physiological review, that normal presentation of comfort regarding Maslow's hierarchy of needs. Subjective data, must understand the normal for that particular patient, and the objective. The sympathetic nervous system response, what happens in that flight or fight response, the stress response, presence or absence of pain, degree of sleep and rest, and the balance of nutrition and fluids. These all bring a sense of comfort to people when everything is just quite in that equilibrium. And again, as I said before, many of these concepts we really look at the lifespan, across the lifespan, starting with our infants. And this could be one of the most challenging populations to determine what is their level of discomfort. How do I know if the baby's hungry? How do I know if there's pain there when he's crying, or is it just the fact that he's lonely or wants to be held? Or he just has a wet diaper. They may perceive pain to a greater extent. And older adults may have a higher pain threshold but lower tolerance. And many of the things that these older patients experience, which I'm sure you're going to see as you continue in your clinical experiences, are the cognitive impairments and the sleep disorders. And there's the ethnicity about being culturally competent. We did talk about that a lot last week. And these are some of the other concepts related to comfort: inflammation, mobility, tissue integrity, grief and loss, and ethics. Because don't always think that discomfort is related to a physical problem. It could be the emotional turmoil that someone is facing, the anxiety, the fear, the pain, the grief. Maybe someone has just lost somebody very dear to them. And I think we all can say that we have experienced some degree of that in our life. Maybe a grandparent, maybe a parent, maybe a pet. All these things, we kind of have that emotional ache that happens when we lose someone that we love so much. Ethics could be there's a emotional discomfort when someone expects us to do something that's against our ethics and our values and our belief. That may present us with a lot of discomfort. So, something to think about. These are 5 common sources of discomfort: pain, end-of-life care, fatigue, fibromyalgia, and sleep-rest disorders. And pain is probably one of the common things we think about when we talk about comfort. Probably one of the most common reasons why a person will seek medical attention. It can be a very unpleasant sensory and emotional experience associated with actual or potential tissue damage, described in terms of damage, plays a protective role, warning of a problem. It's almost the 5th vital sign. Relief of pain is a client right. And this will be what you'll be asking your patient when you do your head-to-toe assessment. You'll do a set of vital signs, and lastly, you'll ask that person, are you having any pain today? And that's what we do, because we know what can happen to somebody and what the physiological response is. Plus, it can cue us into telling us maybe what would be wrong with that person. And pain may be a situation that causes a person a lot of discomfort, but it's also can be a very good thing. And why would I say that? Let me give you an example. If someone is having a heart attack, they're going to have chest pain. So it's the body's way of saying, hey, the heart isn't getting enough oxygen, you are having pain, and you need to seek medical attention. A patient has acute appendicitis. They're going to have extreme pain in their right side. So this is a protective way in which someone does seek medical attention immediately. If we didn't have that pain, we wouldn't know that something seriously wrong is happening within our body. And if we didn't get to the hospital for medical attention, it could be a very serious consequence. Death could happen. And pain is an individual pain event. It's distinct and it's personal experience. We all have a different threshold of pain. Pain 3 on the pain scale, for me, might be very different for you. Maybe that same pain that I say is a 3, you might say is a 7. So it is a very personal experience, and it can be influenced by many factors. How long it lasts, the intensity, where that pain comes from, that's what etiology is, and where that pain is at. And I'm not going to get into these in real detail, but we can look at acute pain versus chronic pain. End-of-life care involves the physical, mental, and emotional comfort, offering that social support given to those living with and dying of advanced illnesses. And we as nurses do have a great impact on these patients that are going through that, as well as their families. Daily activities, providing information, the emotional and spiritual support, and helping families make ethical decisions. And at a time when they are facing these difficulties and this stage in their life, we also have to remember that we want to give them spiritual support, and sometimes that's a very big factor that helps them achieve some type of peace and comfort within themselves. Fatigue, lack of energy and motivation. Acute fatigue, normal tiredness associated with a single event, and sometimes symptoms can resolve quickly. And this is why I have said over and over again, we don't want you as students to get into this situation where you're feeling fatigued day in and day out because you're not really caring for yourself, because you can see that fatigue, lack of sleep, not getting enough rest will eventually bring you a lot of discomfort. I won't get into this about chronic fatigue. This isn't really anything we'll be talking a lot about, but it does entail the concept of comfort. Fibromyalgia is a widespread musculoskeletal pain that includes other symptoms: fatigue, sleep disturbances, and decreased cognitive functioning. This is where a person may exhibit a lot of multiple tender points in precise areas. It's a problem of our central nervous system. It doesn't really have a cure, but it can be treated. We will get into some of the sleep and rest disorders. We know we need sleep. It's a basic human need. It allows the body to enter phases of restoration. Sleep deprivation hinders daily functioning, adversely affects health. And again, I want you all to get your sleep, especially the night before an exam or a quiz or something that's going to take all of your being to be successful at. The IOM recommended more study awareness of problems caused by sleep loss and sleep disturbances. These are some of the common sleep disorders: sleep loss, sleep apnea, insomnia, narcolepsy, parasomnias, and restless leg syndrome. Genetics also affects the susceptibility to diseases associated with discomfort. And some of these disorders directly affect individuals' ability to perceive pain. Genetic mutations associated with some sleep disorders and many psychiatric disorders have genetic components. Prevention begins with the patient, personal preferences, lifestyle habits, nutrition, smoking, alcohol use, sleep hygiene, occupation, and culture. Provide all this information to a person to help decrease their risk. Some people don't realize the importance of sleep, and a lot of people go, wow, I didn't know that I shouldn't do that 1 hour before I go to bed. I thought I was helping myself. This is a reason why I may be not sleeping as well as I could. And as nurses, we do assess our patient's level of discomfort, not only with pain, but we all get that sense when our patients are facing more than just a discomfort of pain. We can sense when they're facing emotional discomfort and how it is affecting maybe their recovery and their restoration to wellness and good health. And thinking about how we go about assessing our patients, and again, looking at the importance of that patient health history, nursing interview, really asking our patients, tell me what you're experiencing. And then when we hear that the patient is having pain, let's go to that pain scale and kind of get an idea of the intensity of that pain. A scale of 0 to 10, 0 being no pain, 10 being the worst pain you could ever imagine. Where is your pain at on that scale? And looking about depression, because when people live with a pain, chronic pain, it does affect their activities of daily living, and these patients can really suffer from serious depression. And client's culture affects how a patient perceives discomfort and expresses pain, and we talked a little bit about that last week. Remember, we had that case study about the patient who refused any pain medication. And I think that was a cultural thing. He was a man and he wanted to endure that pain and work through it. But as nurses, that bothers us because our goal and the role that we took on is to help alleviate some of those situations, and especially when our patients are having pain. And we can tell people are having pain. We can tell when our patient is having pain because a lot of that physical assessment that we do on that patient, particularly vital signs, visual inspection. I mean, if we look at someone who just had surgery and we look at a wound and we see that that wound is infected, inflamed, swollen, we pretty much have a good sense that that patient is experiencing a lot of pain in that area. We can diagnose patients that have, urinary tract infections, which can bring a lot of pain, by doing a culture and sensitivity on that urine. So analyzing blood and urine, doing blood test, diagnostic test, x-rays, blood test, all those things help us to better get an idea of what's going on with these patients. Age and developmental stage affect ability to describe pain, and that makes sense because, as I said earlier, an infant can't talk, so they're not going to be able to say, hey, my tummy hurts after I just got that bottle of formula. They might display their discomfort in a different way. Crying, face turns red, all the signs that you would see a baby do when they're having discomfort. So there are special considerations for assessing discomfort and promoting comfort for each stage. And think about how different cultures express their pain. And these are just some of the diagnostics. I'm not going to get into that. We're not going to really discuss that a lot. But just to know that that helps us better understand if our patients are having pain, what is the cause of that pain. And we learn a lot by diagnostic studies. So again, as nurses, doing that interview, learning about the patient's health history, we can hopefully identify those sources of discomfort. And relieving that pain is really a big priority as what we do for that patient. And it doesn't necessarily mean that we have to turn right away to medication. Many times we can help these patients with non-pharmacological measures. But if they're not identified, maybe we're not providing them the best intervention to help them with their pain. We'll talk about this a little later when we discuss more about sleep hygiene.
Scale of 1 to 10, what would you rate your pain?
Oh, 10.
You don't look like you are in that much pain. So, 1 is like you aren't having much pain, and a 10 is like you are having the worst pain of your life. So what is your pain?
10.
Okay, so a 10 is like you are rolling on the ground in pain. So what is your pain now?
It hurts a lot. It's definitely a 10.
I don't think I'm making myself clear. You look perfectly fine. You are not even wincing, even a little. I've seen people lying on the beach look like they are in more pain than you are.
Oh, well.
A 10 is like you've just fallen off a building, or have just been hit by a car going like 50 miles per hour, or something like that.
Yeah, I feel like that.
Really? A 10 is like your limb is being chewed by a wild animal, or you've been beaten for an hour by the Bloods and the Crips both.
Wow, it's like you are reading my mind.
Right. A 10 is like a boulder has just fallen off a cliff and landed directly on your head and crushed every bone in your body. Or, have you seen Braveheart?
Yeah.
A 10 is like when they tied a rope to each of his limbs and pulled each rope in different directions. It's like the worst torture you can imagine. It's like being eaten alive by fire ants. Like being burned alive. Like having root canals in each of your teeth without any anesthetic. It's horrific. You would practically be dead. So, what is your pain?
Oh, then it's a 12.
I quit. I cannot deal with you people any longer. Where's my manager? I quit right now.
Can I have something lauded now?
Hello, Mrs. Frequent Flyer. What brings you to the ER today? I think I have the Tipton flu. The what flu, ma'am? The Tipton.
I hope you enjoyed that last video I just showed you. It's a little bit of a satire on pain assessment, but I think it gets the word across that you do see some professionals, healthcare providers, really not listen to the patient. And again, I think it's important to stress this statement that I'm going to tell you in just a few minutes is, pain is what the patient says his pain is. Maybe you look at him or her and they tell you that they have a pain of 8 to 9, but they're laying in their bed and they're on their cell phone talking and laughing and having a great time. You cannot dispute that in regards to your patients verbalizing that that's what their pain level is. And I think this is what the video was trying to get across. She kept saying, it can't be that high. If you had a pain that high, it would be just like, as she described what excruciating pain would be like. And then no matter what the patient told her her pain level was, she never believed her. Well, it can't be that, because if you were having that kind of pain, you would be experiencing whatever the case may be. And then, you know, at the end, she's like, well, can I still get something for pain? And the nurse or whoever that patient, you know, provider was said, you know, whatever. So I think it, you know, brings out a good message that we as nurses cannot be judgmental about the pain that our patients verbalize and say that they have. And we do see nurses do this. We label those patients as medication seekers. But you know what? It could be that pain that the patient is describing. So I just thought that you know, video was quite cute, but at the same time, it really gave us a good message on we need to believe our patients, you know. And then we may ask them further, tell me more about your pain. You know, what aggravates it? You know, according to that old cart, you know, we may do you know, further question the patient so we get a really better idea of what that patient's pain level is, along with what's that pain really like. I hope that you take the time to review the videos that I've downloaded in Canvas for you, the General Survey History and Techniques, Pain Assessment, Pain Management Kit, and the Pain or Pain Intervention and Pain Assessment video. They're all rather short. It won't take you very long to review those, but please do that at your leisure. So, as I said that, again, a reminder that as we assess our patient's pain level, use those two acronyms, old CART. O for onset, L for location, D for duration, C for characteristics, A for aggravating factors, R for relieving factors, and T for treatment. And ICE is I for impact on daily activities, C is for coping strategies, and E is for emotional response. I think those are really good. How does this pain impact your daily activities? Well, my pain is so bad that I can't get into the bathtub anymore, and because of that, I can't provide daily hygiene to myself anymore because I'm worried I'm going to fall. But it really hurts so bad to you know, lift my leg and to get into the bathtub. So these are things that, you know, your patient may say to you that helps give you a better idea that, yeah, this pain is really bad because it is really impacting their activities of daily living. As we continue with the concept of comfort, we've touched upon pain, which definitely is a way to assess our patient's level of comfort. And now we move on to sleep. As I said when we were making that list in the beginning of this presentation, if you've got a person who really is having difficulties sleeping, or when they do sleep, they're woken up many times during the night for various reasons, or sometimes it's just very difficult for them to get to sleep. And I sometimes have those issues where you have a lot on your mind, you lay in bed, you can't turn off those thoughts, so it's definitely affecting your sleep. And sleep hygiene is absolutely imperative for providing comfort and feeling refreshed and in good health. It really does give us a sense of wellness when we're getting a good night's sleep. And your book talks about sleep hygiene, and even these videos that I've asked you to watch, the stages of sleep, REM sleep part 1, and the sleep cycles over the course of a night. I've asked you to look in your clinical nursing skills book and look at the skill 3.6, which is about sleep promotion. Sleep is the body's time to refresh, restore, and prepare for the next day of activities. Adequate sleep time is important to mental and physical well-being, and helps the brain to process information, learn, and remember. It can improve an individual's ability to tolerate pain by decreasing pain sensitivity, and people with chronic and acute pain often lose a sleep time, which can affect their daily routines. So helping patients in pain get a good night's sleep is important to their health and quality of life. And so again, as nurses, we don't need a lot of fancy equipment to help promote relaxation before bedtime. And it really is our responsibility to make sure that our patients are getting some rest. That's why we need to have organized care for these patients. Make sure that we do offer them periods of rest, that we're not in their room every hour, that when we do offer them maybe a pain medication, that we allow that pain medication to work so that our patients can sleep and the healing process can begin. And we are responsible, as your book says, to assess the patient's readiness to make changes in health behaviors to promote improved health and well-being. And we as nurses can teach and coach the patient about integrative health care strategies focused on sleep promoting relaxation. And then you can offer this information to your UAP, who can then assist the patient in these activities to help the patient be more comfortable and prepare for sleep. So the nurse will instruct the UAP to report patient observations to the nurse for follow-up. How's the patient doing? And that's one thing I used to always do in the morning when our patients used to arrive at the clinical facility. As they were getting a report from the nurses, I used to go in and visit all their assigned patients. And as I did that, one of my first questions was to each patient was, how did you sleep last night? And that really gave me a sense of maybe the kind of day that they were going to have. Oh, I didn't sleep well. And I used to say, well, what happened? Why didn't you sleep at all last night? Well, I was in a lot of pain and I knew the nurses were busy, so I didn't bother asking for something for pain. Or I'm really worried about something going on in my house, blah, 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 and they start telling you a little bit about why they weren't getting enough sleep. Oh, there was a lot of noise out at the nurse's station, and every time I tried to fall asleep, they were out there laughing and talking about what they did in the past weekend. So these are some of the cues that I listened to make sure and understand why that patient didn't get enough sleep that night, because it's absolutely necessary that our patients are getting their sleep. So I'd like you to definitely look at this particular section in your scales book. And again, things that we might teach our patient about sleep would be to establish a regular bedtime and wake-up time for all days of the week to enhance biological rhythm. Sometimes a short nap, say for 15 or 30 minutes, particularly among older adults, can be restorative and not interfere with a nighttime sleep. But if you're a young person and you have insomnia, you really should not nap, because those are the things that are going to keep you up all night. Establish a regular, relaxing bedtime routine before sleep, such as reading, listening to soft music, taking a warm bath, or doing some other quiet activities you enjoy. Avoid dealing with office work or family problems. Get adequate exercise during the day to reduce stress, but it's very important the time of day when you do this exercise. Avoid excessive physical exertion at least 3 hours before bedtime, and use the bed for sleep or sexual activity so that you associate it with sleep. Take work materials, computers, and TVs out of the bedroom. Lying awake, tossing and turning will strengthen the association between wakefulness and lying in bed. Many people with insomnia report falling asleep in a chair or in the front of the TV, but then have trouble falling asleep in bed. And if you do have problems sleeping, it's recommended to get out of bed, go into another room, and pursue some relaxing activity until you feel drowsy. Make sure the environment is comfortable, the temperature, block out some extraneous noises as necessary with white noise from a fan, an air conditioner, or white noise machine. It's really recommended that music is not recommended, as studies have shown that music promotes wakefulness because it is interesting and people will pay attention to it. Sleep on a comfortable mattress and pillow, and avoid heavy meals. Avoid alcohol and caffeine at least 4 hours before bedtime, because caffeine can interfere with sleep, and both caffeine and alcohol act as diuretics, so what's going to happen is you're going to get up in the middle of the night and have to use the restroom. Use sleep medications only as a last resort. Use over-the-counter medications sparingly, and take analgesics before bedtime to relieve aches and pains, and consult healthcare provider about adjusting other medications that actually may be causing the insomnia. So I think this really gives us some great advice and what some of the things that we can teach our patients about how to get a better night's sleep. The next section is about evidence-based practice about sleep quality, and we look at the lifespan's considerations, starting with children through adults, and then going through the lifespan of an older adult. I'm not going to read all that to you, but some great information about some of the things that have proven to be helpful, and some of the things that we see of the causes of why these particular age groups are not getting good sleep. So please be sure you review those, okay? Children may have trained night feeders. Those are infants who are fed during the night and are fed until they fall asleep, and then they're put into the bed. Then we have sleep refusal, where many toddlers and young children are resistant to settling down to sleep. And then, of course, the night terrors. And then this can very much relate to the population that you're caring for, the older adults. These are reasons why they have problems falling asleep. Side effects of meds, GI disturbances, their respiratory and circulatory disorders, pain from arthritis, increased stiffness, nocturia, depression, loss of life of their partner and close friends, and confusion that's related to the delirium or dementia. So, very important stuff. And again, here's some important information about sleep hygiene on the PowerPoint that I have here in front of you, and I'll let you review that also. Psychosocial well-being, laughter, positive attitude, participation in enjoyable activities, interactions with family and friends, and support groups. And sometimes it's just a matter of coming home and relaxing and putting all the work responsibilities or school responsibilities behind you so that you can begin to wind down and relax so that you can prepare yourself for your bedtime. And sometimes just doing nice meditation, breathing exercises, imagery, or other forms could be massage, acupuncture, meditation, and biofeedback. And that pretty much concludes the information in that PowerPoint, which I I hope that you found very helpful. I have provided a article titled Rest and Sleep, and it just defines a lot of the terms that are associated with sleep, and one of them is insomnia, non-REM sleep, and we see people suffer from that problem as well. Narcolepsy, hypersomnia, parasomnia, sleep apnea, and circadian rhythms. Also looking at how to assess the client's need for sleep and rest, and how we can intervene and hopefully help those clients reach and obtain the sleep that's needed. It's really recommended how much sleep our certain age population should be receiving a night. Neonates through 3 months of age typically sleep about 14 to 17 hours a day. Infants from 4 months to 11 months sleep about 12 to 15 hours a day. Older infants and toddlers up to 3 years of age should sleep about 11 to 14 hours a day. Your preschool age group from 3 to 5 sleep about 10 to 13 hours a day, or at least should. School age kids, and this is important now when our kids start going to school, that they're getting enough rest. They should be sleeping about 9 to 11 hours a day between the ages of 6 to 12. Adolescents between the ages of 13 and 17 should sleep about 8 to 10 hours a day. And young adults and middle-aged adults need about 7 to 9 hours of day. 9 hours of sleep a day, and then older adults over 65 require about 7 to 8 hours of sleep per night. And there are many factors that may impact or impair that those hours of sleep that are recommended, and illnesses, and that makes sense. Some of the physical diseases, for instance, pain. Some of our patients, like I said before, who have respiratory diseases or GI diseases, hypothyroidism, all those can be a very good reason why these patients are not sleeping very well. Medications, environment, some of the emotions that we face, lifestyle choices, and that would mean like smoking before bedtime, drinking alcohol right before bedtime, drinking caffeine, our work schedules. A lot of research looks at how people sleep who work the day shift versus people who work the night shift. So we look at some of the reasons why our patients are having problems, and many times, they're not really ready for sleep yet, or sometimes insomnia can be related to a lot of anxiety and stress that they're facing in their life. Sometimes people who travel a lot, they face a lot of jet lag, so this really brings about a lot of sleep deprivation. People who work the night shift. I could never work the night shift. I never slept well at all. I always felt exhausted and tired. Some people that actually have physical problems like sleep apnea. People that have respiratory issues that cause them to have impaired gas exchange. Alcohol use. So these are things that we really need to think about and find out the reason why our patients are not sleeping, because we as nurses can provide them a lot of great information to help them get a better night's sleep. Well, this concludes the information that we would have talked about in class. regarding our concept of comfort. I will provide additional information in another lecture on the concept of legal in regards to social media. So stay tuned for that, and be sure that you view this over the holiday weekend, because we would have talked about this in class as well.